Good afternoon, students. My name is Oksana Gudzenko. I am Associated Professor of the Department of Infectious Diseases in our university. And today, we bring to your attention a lecture about relatively new but extremely prevalent disease, COVID-19. I hope information will be useful for you and will help you to be able to describe principles of transmission, spread, current epidemiological peculiarities of COVID-19, explain the key points of pathophysiology of the disease, be able to recognize the disease, assess indications of admission of patient with COVID-19 to a hospital, know and use in your practice the principles of lab monitoring, diagnosis, management, and prevention of COVID-19. So, coronavirus disease 2019 is a highly contagious illness caused by a newly discovered coronavirus called SARS-CoV-2. The disease was firstly reported in the city of Wuhan, Hubei province, China, in December of 2019, and then after it quickly spreads worldwide, resulting in the pandemic. COVID-19 was declared as a pandemic by the World Health Organization on March 11th, 2020, mainly due to the speed and scale of transmission of the disease. During the pandemic, more than 600 million people around the world fell ill. Over 6.8 million died. On May 5, 2023, situation. The World Health Organization announced that COVID-19 is now an established and ongoing public health concern that is no longer a public health emergency of international concern. Nevertheless, COVID-19 remains an uncontrolled disease today due to unique variability of the pathogen, lack of protective post-infectious immunity, and low effectiveness of vaccination. As of April 13, 2024, the coronavirus track is no longer being updated due to the unfeasibility of providing statistically valid global totals, as the majority of countries have now stopped reporting. Nevertheless, as of April 14, as of April 13, 2024, there are more than 700 confirmed cases globally, with more than 7 million deaths, according to World Health Organization statistics. With the global coronavirus pandemic, a majority of the world population is now estimated to have some immunity to SARS-CoV-2 through vaccination or natural infection, but its effects are still being felt in the form of COVID-19 outbreaks from emergent subvariants, lasting symptoms like post-acute sequelae of COVID-19 or long COVID, excess population mortality, and more. The region and source of the SARS-CoV-2 remains unclear. Also, the initial cases have been associated with the Wuhan, South China seafood market, where snakes, birds, and other animals such as bats were sold. Don't exclude the laboratory origin of the virus. The debate continues to this day. Nevertheless, a suspected beta region was suggested after 96% genome sequence identity was demonstrated between SARS-CoV-2 and another coronavirus isolated from bat species. Pangolins were also suggested as natural host of coronaviruses. The most probably, virus crossed the species barrier and entered the human population in result of viral evolution under influence of environmental and human-associated factors like globalization, deforestation, etc. It was estimated that SARS-CoV-2 has circulated in human population not earlier since November 2019, and soon after realization of human-to-human transmission had started pandemic scenario. World Health Organization uses a six-phase scale of pandemic alert to inform the world of the global spread of a new agent. The scale is also used as a global framework for countries during pandemic preparedness and response planning. Non-pandemic phase is characterized with low risk of human cases. It is through not only for COVID-19, it is low for any infectious disease with potential pandemic spread. The following conditions must be met for a pandemic ensure. First, novel virus has to retain the ability to replicate well in humans. Important note, little or no immunity in the population. The next, efficient and sustained person-to-person transmission between humans. And it is crucial that virus must balance high pathogenicity with high virulence, demonstrate an ability to cause serious disease with high mortality rate. SARS-CoV-2, agent of COVID-19, is member of coronavirus family. It is large family for viruses. Some cause illness in people and others only infect animals. Some coronaviruses primarily infect animals, then overcome the species barrier and spread to people, and then spread person to person among human, such as Middle East respiratory syndrome, agent severe acute respiratory syndrome virus, and agent of COVID-19. No appearance, coronavirus have a crown-like appearance, any coronavirus, under the microscope. It is basis of name of this virus, coronavirus. Several subgroups are involved in coronavirus family. SARS-CoV-2 belongs to genus B coronavirus, subgenus Sarbecavirus, lineage B. At least 7 members of coronavirus family cause disease in human or are high contagious. Mostly they cause mild respiratory disease, but 3 of them are characterized with higher pathogenicity and may cause severe disease with serious prognosis. Severe acute respiratory syndrome, Middle East respiratory syndrome, and COVID-19. So, epidemics of severe acute respiratory syndrome 2002-2004 was characterized with comparatively high mortality rate, 10% of mortality rate. Middle East respiratory syndrome has been known since 2012. It's spread in 27 countries and it is characterized with 35% mortality rate. SARS-CoV-2 is closely related to the original SARS-CoV-2 agent of severe respiratory syndrome. It is thought to have a zoonotic origin. Like other coronaviruses, SARS-CoV-2 is characterized by the presence of crown-like spikes on their surface. It is enveloped virus containing positive sense single-stranded RNA, genome encodes for 29 proteins involved in the infection, replication, and virion assembly process. The spike S protein from SARS-CoV-2 contains a receptor binding domain that binds the human angiotensin converting enzyme 2, ACE2. And therapy promotes membrane fusion and uptake of the virus into human cells by endocytosis. So, four structure proteins are important and encoded by genes of agent. Spike protein, membrane protein, envelope, and nucleocapsid. Spike protein consists of two parts. S1 that is responsible for attachment of receptor, and S2 that is responsible of membrane fusion. SARS-CoV-2 is one of the most changeable agents in nature. This is why it escapes past infection and past vaccination immunity and may cause repeated infections. The many thousands of SARS-CoV-2 variants are grouped into either clades and lineages. As of December 2021, there are 5 dominant variants of SARS-CoV-2 spreading among global populations. This is why several waves of morbidity were observed globally, caused by Alpha, United Kingdom, Beta, South Africa, Gamma, primarily found in Brazil, Delta, formerly called the India variant, and finally Omicron variant, which became dominant during last year, particular subtype of Omicron, Kraken. This variant causes less severe illness, but demonstrates high transmissibility. Nevertheless, some patients die from COVID-19, in particular, even infected by Omicron, particular from groups at risk. COVID-19 is typical respiratory infection. The dominant way of transmission is airdrop or respiratory. And it virus is spread from person to person, mainly through coughing, sneezing, talking, and breathing due respiratory secretions. It's evident the risk of transmission is highest when people are in close proximity. Transmission can also occur in contaminated fluids. Respiratory secretions are when respiratory secretions are splashed or splayed in the eyes, nose, or mouth, or more rarely via contaminated surfaces. Contact touching way of transmission is realized rarely because virus isn't resistant in the environment. Also, it may survive on different surfaces from several hours into up to 5 days, depending on type of these sepsis. Basics in pathophysiology. So, application of SARS-CoV-2 is multi-stages process. Virus uses angiotensin enzyme angiotensin converting enzyme 2 for viral entry into the host cells. So the main target cells for SARS-CoV-2 are cells expressing ACE2 receptor on their surfaces. First of all, rhinopharynx and lung epithelial cells, vascular endothelial cells, alveolar macrophages, and some other cells. Spike proteins of agent-mediated attachment and endocytosis through ACE2 receptor and certain co-receptor named TMPRCSS2 co-receptor is important for attachment. Except receptor angiotensin converting enzyme 2 receptor. Since that, viral replication starts. In host cells, virus initiates direct cytolytic process called pyroptosis cascade. As you see, pyroptosis cascade is form of plant cell death with high inflammatory pattern associated to some cytopathic viruses. In adapted immune response, generation of pro-inflammatory cytokines and chemokines leads to efficient retrofeedback. It is part of efficient immune response, implemented by CD8, CD4 T cells, NK, and other immune-mediated cells, resulting clearance of infected cells through phagocytosis of infected and neutralized cells of macrophages, and inactivation of virion by neutralizing antibodies. In COVID-19, absence of retrofeedback with accumulation of macrophages monocytes, cell producing interferon gamma, and overproduction of pro-inflammatory cytokines like interleukin 2, interleukin 6, tumor necrosis factor, and others, lead to additional immune-mediated damage of tissues. This pathological process is called cytokine release syndrome or cytokine storm. Antibody-dependent enhancement is seen. Increased production of virions through a paradoxical response associated with non-neutralizing antibodies. Cytokine storm also leads to activation of coagulation pathways, resulting imbalance between pro and anticoagulant factors that finally leads to microthrombosis, DIC syndrome, that contributes multi-organ failure. So the main pathophysiological links of COVID-19 are renin-angiotensin system dysregulation, activation of innate and adaptive immune pathways, cytokine release syndrome or cytokine storm, and hypercoagulation result in coagulation pathway. In severe cases, multi-organ damage with kidney, heart, lungs, vessel, immune system dysregulation are predominant. The lungs are the most affected organ in COVID-19 because a receptor for angiotensin converting enzyme 2, ACE2, is most abundant of the surface of type 2 alveolar cells of the lungs. In severe cases, cytokine release syndrome storm, as a result of hyperinflammatory response, plays a predominant role in causing of acute respiratory distress syndrome, extremely severe complication of COVID-19 that is characterized with increased microvasal permeability, widened edematous interstitium, swollen injured endothelial cells, microthrombosis in vessels, and the influence of hyperproduction of pro-inflammatory cytokines. Additional pathogenetic role belongs to secondary bacterial infection, resulting septic complications in severe cases. So, clinical manifestations. At least a third of people who are infected don't develop noticeable symptoms. Among symptomatic patients, more than 80% develop mild to moderate symptoms, while 14 develop severe symptoms with signs of lung insufficiency, and 5% develop critical symptoms like severe respiratory failure, shock, and signs of multi-organ dysfunction. Incubation period for COVID-19, I am sure you know this term, incubation period. The incubation period in COVID-19 ranges from 1 to 14 days, most commonly around 5 days. People are most contagious when they are the most symptomatic. Usually, it means the first 7 days after onset of the disease. But they may remain contagious for up to 2 weeks and can spread the virus even if they don't develop symptoms. It is the most important in the epidemiological spread of the disease. Several studies show people may be contagious one day before developing of symptoms. The symptoms of COVID-19 are variable, but often include fever, cough, breathing difficulties, loss of smell, anosmia, loss of taste. Other signs, commonly, disease is characterized with common features for any respiratory infection. The most common symptoms include signs of severe intoxication, may be severe, may not, with fever. Fever may be prolonged, 1 week, even more than 1 week. In other presentations of intoxication, like body ache, headache, weakness, loss of appetite, dry cough is commonly seen in initial stage of the disease. And shortness of breath is in more severe cases. Other symptoms may include sore throat, runny or stuffy nose, body aches, chills, fatigue, sometimes gastrointestinal presentations like diarrhea, nausea, and stomach ache. No, loss of smell and taste are typical for COVID-19 and usually signal about mild or moderate severe cases, but presence of these symptoms don't exclude possible severe course of the disease. Natural history of COVID-19 is presented on this slide. Disease may be divided into three stages. Early infection, stage of early infection, named viral response phase, is characterized by prevalence of direct cytolytic virus action. Stage is characterized with high level of viral replication accompanied with adaptive immune response. This stage is constantly seen in all patients, independent on severity. And by the way, severity of illness becomes evident not since the first days of illness. Usually during the first later during the first during second week or after onset of the disease. Pulmonary, the next pulmonary stage. Pulmonary stage is divided into stage pulmonary stage A and pulmonary stage B. No, pulmonary phase means appearance of signs of pneumonia. As a result of viral action, predominantly viral action in stage 2A, and then after in more severe phase, in more severe cases, immune-related inflammation that may progresses to transform to hyperinflammation phase, stage 3, when patient is severe, critical condition, patient is demonstrates acute respiratory distress syndrome, shock, and other severe complications. And pathogenetically, disease is characterized with hyperinflammation as a result of cytokine release syndrome. In this stage, elevation of inflammatory markers is predominant, like CRP, D-dimer, ferritin, and others. So, disease in half of patient disease is asymptomatic, but patient may be involved in patient is involved in epidemiological process and may spread disease to other person. In this person, patient disease may transform to the severe course. Yeah. Mild disease is characterized as signs of intoxication. By the way, level of fever is not the main sign of main indicator of severity. Fever in patients with coronavirus disease may be prolonged, may last more than 7 days, and may be higher than 7, may be high. It doesn't mean further severe course with mild organ failure or severe respiratory insufficiency. So mild disease is characterized with signs of intoxication and respiratory signs. Mild inflammatory lesions possible due to CT examination, like less opacities in circulation, without any signs of respiratory failure. Moderate severe. Moderate severe is characterized with predominant illness of lower respiratory tract, due certain complaints, dry cough, physical examination with most rails, and method visualizations may demonstrate, and usually demonstrate typical infiltration in the lungs. In moderate severe cases, SpO2 usually not lower than 90%. If higher, we may talk about more severe cause, because saturation higher than 93% is the first presentation of hypoxia and respiratory failure. This cause is characterized additionally with other signs of respiratory failure, like respiratory rate higher than 33, partial decreasing of partial oxygen, disturbances of arterial blood gases, progression of pulmonary infiltrate to more than 50% for a day, and quick worsening of patient. Critical course of the disease so severe COVID-19, with one of least complicated complications like acute respiratory distress syndrome, sepsis, confusion, pulmonary organ failure, thrombosis, CNS involvement, like encephalitis and others. So COVID-19 is characterized, except respiratory presentations, extra respiratory manifestations are common from different organs. Gastrointestinal presentations are the most common are diarrhea, stomachache, nausea, dermatological. Any kinds of rash may be seen, usually erythematous rash, spots, but petechia possible. Acute kidney injury with proteinuria and other laboratory presentations, hepatic involvement with increased transferase activity. Cardiac involvement with arrhythmias, myocarditis, signs of myocarditis, neurologic, dizziness, algesia, anosmia, stroke, possible thromboembolism. No, we may talk about complication, thromboembolism, but coagulation, changing are common in any severity of the disease. So, among the most common complications and the most severe complications, respiratory failure, acute respiratory distress syndrome, of course, the most commonly seen, thromboembolic, like pulmonary embolism, ischemic events, strokes, myocardial infarction, etc. Arrhythmias, myocarditis, neurological encephalitis, Guillain-Barré syndrome, encephalopathy, acute kidney failure, secondary bacterial infections, bacterial pneumonia, up to septicemia and sepsis. COVID-19 poses a great risk for severe illness for elderly people and for persons with underlying health conditions like hypertension, arterial hypertension, coronary heart disease, chronic lung disorders such as particular obstructive diseases such as asthma and obstructive bronchitis. Metabolic disorders with diabetes mellitus, obesity, steatosis of the liver, chronic illnesses of kidney, suppress immune system of different origin. All these conditions are risky for severe course of the disease. Immunological predictive factors and some genetic disposition of the disease severity are now in the field of interest of many scientists. No, it is evident that very strong association of severe forms of COVID-19 and anti-interferon type 1, also antibodies, more prevalent in elder males. So, confirmed case means a suspect case with laboratory confirmed diagnostic evidence of SARS-CoV-2 virus infection. Disease is confirmed by the list of specific diagnostic tests. No, primary testing is based on antigen detection. It is a rapid test. Antigen detection by immunochromatography detection in nasal and pharyngeal swabs. Absolutely available and today is used in any department, and patient may use this test for self-controlling, controlling without doctor's consultation. The next step is PCR detection, real-time PCR based on RNA detection of SARS-CoV-2 in nasal and pharyngeal swabs. When we talk about serological examination is not so important in diagnosis of confirmed case. No, today enzyme link immunosorbent assay is the most popular. Serologic examination allows to identify specific IgM and IgG, but not so demonstrative in primary diagnosis of COVID-19. And isolation of SARS-CoV-2 is not recommended in practice. Virological examination is used in manufacture of vaccines and in scientific researches. It is evident that methods of direct identification of RNA or antigen of SARS-CoV-2 are the most resultative in initial stage of the disease. Antibody become detectable later and may remain positive while months and after infection, and even years after the infection and vaccination. Positive antibodies doesn't confirm case of COVID-19. Some people continue to experience of a range of effects, long COVID, for months after recovery, and damage to organs has been observed. Signs may be different, including fatigue, muscular weakness, joint pain, prolonged cough, persistent oxygen requirements sometimes, from neurological nervous system, anxiety, sleep disturbances, cognitive disturbances, repeated headache, chest pain, thromboembolism, chronic kidney disorders, and others. Mm. Multi-year studies are underway to investigate the long-term effects of the disease. Non-specific laboratory examination is so important for COVID patients, for monitoring of COVID patients. CBC demonstrates leukopenia, severe lymphopenia, less than 1,000 in 1 microliter, is predictor of severe course of COVID-19. CRP-ferritin increase interleukin-6 signal about cytokine release syndrome. Clotting test monitoring is important to prevent thrombolytic complications. Blood glucose, liver and kidney function test, electrolyte acid balance, arterial blood gases in severe patients. Procalcitonin is predictor of secondary bacterial complications. Bacterial culture of sputum is part of, usually is part of standard examination of patient with pneumonia. In the case of COVID-19, may be informed in bacterial agent of secondary bacterial pneumonia in patient with COVID-19. Methods visualization, chest X-ray or CT, scan is used, ECG, and of course monitoring of SpO2. Different types of different methods of visualization are used. First of all, X-ray examination that may reveal glass opacities, typical glass opacities infiltration, CT of the chest, and for monitoring of dynamics of condition of lungs. Ultrasound examination is so popular today. Typical picture of lungs, X-ray picture of lungs, multifocal ground glass opacities with peripheral and subpleural localization are seen. Many drugs have been used since the start of the pandemic. Today we understand this disease much better. And as for me, in my opinion, the greatest achievement of learning of COVID-19 is refusing from useless medications in treatment. 30-year experience in therapy of COVID-19 patients allows to prescribe medications much more reasonably, to use new synthesized antiviral drugs, to avoid polypragmasia and useless drugs. Today we know that the same drug may treat patient, but may kill him. depending on term and cause of the disease. I have to return to my favorite picture. No, if you analyze it, it is evident for you what stage of the disease is so sensible. In what stage of the disease patient is sensible to antiviral drugs? Of course, stage early viral infection associated with high level of viral replication. First 5 days after onset of the disease, you have to prescribe antiviral drugs and you will receive results. When we talk about steroid therapy, what the most recommended refuge on this slide, yeah? First of all, you have to understand goal of prescription. What aim of prescription of steroid therapy? Suppress hyperinflammation phase. What term for hyperinflammation phase? Not early stage of the disease. Hyperinflammation phase is characterized with severe pneumonia, with increased pro-inflammatory enzymes in the blood and clinically evident respiratory failure. In this case, immunosuppression plays a positive role in treatment of patients. But if you prescribe steroid therapy in initial stage, in viral stage, this immunosuppression is harmful for patient because replication becomes easy, and this immunosuppressed action influence to suppression of natural immunity against natural resistance against viral infection. One of the greatest achievements of therapy in COVID-19 was introduction of antivirals. Today, several drugs may be used to suppress, specifically suppress SARS-CoV-2. Paxlovid, molnupiravir, and remdesivir. Paxlovid and molnupiravir may be prescribed, may be administered orally, and remdesivir IV. What indications for prescription of antivirals? Well, first of all, you have to prescribe them to initial stage, but presentations of initial stage is not recognized like further severe course. You may prognose severe course, only your prognosis may be based on analysis of groups at risk. So it is why, first of all, oral antiviral drugs are recommended, first of all, in initial stage of the disease in outpatient department for patient from group at risk. All other patients may be treated by supportive care, like other patients with upper respiratory tract viral infection, but be attentive. Sometimes even patient with absence of absence of signs of maybe due to history of life, absence of groups at risk, demonstrate severe course of the disease. In our hospital, the first patient who died from COVID-19 was a sportsman, 30 years old, father of 2 children, sportsman, no, without evident presentations of comorbidities, but autopsy revealed steatosis of the liver. So that is why risky, maybe not so evident, or fully evident. So principles, no. Principles of treatment. The next. Avoid, no, first of all, avoid misuse of useless medications. It is the most important principle. Prone position in the bed. Prone position in the bed means position on the stomach. Why? Because inflammation, infiltrative locuses focuses in the lungs, mostly locates in dorsal part of the lungs, subpleural. That is why prone position in the bed may improve condition of patients and influence to easy breathing of these patients. Oxygen delivery is one of the most important vectors of treatment, with different regimens of oxygenation, depending on severity, depending on answer, patient to previous regimen of oxygenation. Our aim to reach SpO2 higher than 93%. Antivirals, remdesivir, Paxlovid, molnupiravir, ill prophylaxis of hypercoagulation, usually low molecular heparins are recommended. Steroid therapy in form of methylprednisolone, 32 milligram per day, or dexamethasone, 6 milligram day in patients with respiratory failure only. But be careful. In the beginning of respiratory failure, steroid therapy is the most effective. When patient demonstrates 50% of saturation, even high doses of steroid therapy are considerably less effective. Tocilizumab. Tocilizumab is well known among rheumatologists. It is selective inhibitor of interleukin-6, is used in severe cases of COVID-19 in dose of 8 milligram per kilogram IV, but it is so strong. Tocilizumab is severe immunosuppressive medications, and that is why before prescription of this medication you have to check patient for transferase activity. Liver disorders is one of the contraindications, and another one is any bacterial infection, because in case of secondary bacterial infection, prescription of tocilizumab may lead to septicemia and sepsis due to progression of immunodeficiency. Supportive care, like in other respiratory upper tract viral infection, detoxification, antipyretics, vitamin D, and other vitamins, and so on. It is important. Antibiotics, absolutely useless in viral infection. Only documented secondary bacterial pneumonia or bacterial infection or involved of other patient with indication for this kind of treatment. Several additional words about antivirals. Paxlovid includes nirmatrelvir, a protease inhibitor, boosted by ritonavir. Is recommended for treatment of adults and pediatric patients, but elder than 12 years with current diagnosis of mild to moderate COVID-19 and who are at high risk for progression of severe COVID-19, including hospitalization or death. Initiate Paxlovid treatment is as soon as possible after diagnosis of COVID-19 and within 5 days of symptom onset. Administer orally with or without food. The dosage is standard, 300 milligrams of nirmatrelvir with 100 milligrams of ritonavir twice a day. And usually, but Paxlovid is before prescribing Paxlovid, we have to analyze situation and be attentive for kidney failure, for interaction of Paxlovid with many other medications. Some of these interactions may be harmful to the patient, like interaction of Paxlovid with some anti-arrhythmias, arrhythmic medications. And Paxlovid is accompanied with a list of side effects. Intestinal infections, first of all, gastrointestinal, vomiting, nausea, severe nausea, weakness. These side effects limit using of this medication. Remdesivir is a nucleotide prodrug of adenosine and annealage that inhibits SARS-CoV-2 replication. It is not a new drug, primarily was used in treatment of Ebola disease, but is effective against COVID-19. Among advantages is possible use in babies, but IV administration limits using of remdesivir, particularly in stage in outpatient treatment when in period when this medication, like other antibiotics, is the most effective. Molnupiravir is the oral prodrug of hydroxyzidine, ribonucleic that has inhibits antiviral activity against SARS-CoV-2, active against all variants of COVID, and may be used, and by the way is accompanied with minimal side effects. 4 tablets twice a day is administration of this therapy. Treatment should be initiated as soon as possible and within 5 days of symptom onset, like other antivirals. Prevention of COVID-19. First of all, non-specific prevention directed to rupture of route of transmission is effective and is the same with measures recommended for prevention of other respiratory tract viral infection. Wearing of mask, be informed and prepared, maintain social distancing, not less than 6 feet, wash hands frequently with using of alcohol-based hand sanitizer. avoidance of touching eyes, nose, and mouth. Stay home when you are sick. Cough or sneeze into a tissue or you billable, clean and disinfect frequently touched objects and surfaces such as cell phones. When we talk about specific prevention measures, no, different types of vaccines were proposed and were used in prevention of COVID-19, among them viral inactivated vaccines, viral vector, RNA vaccines, but unfortunately even repeated even revaccination couldn't prevent repeated COVID-19, but experience demonstrates that mortality rate significantly lower among people with vaccinated, fully vaccinated before admission to the department. Today, you may find in scientific publications discussion about side effects of vaccine, thrombotic complications, also immune disturbances, but according to recommendations, patients from group at risk should be vaccinated against COVID-19 to avoid unfavorable prognosis of the disease. It is clear that with the end of the COVID-19 pandemic, SARS-CoV-2 is circulating among people, like flu viruses or other agents of upper respiratory viral infections. And it will not be eliminated from human population in the near future. Every day we gain new knowledge that step by step brings us closer to the time when we will be able to fully control COVID-19. So if you have any questions, please welcome to ask me or another teachers during practical classes. It will be interesting discussion. And now I say you goodbye and thank you for your attention today.